what we're going to do is by the end of this training, we want you to be able to develop a relevant and effective hazard vulnerability analysis. There's a lot of people out there, and I'm not saying any one of you are in here that do that, but you simply just go through the motions to check a box. You come to these meetings, you sit in your hospital, you have meetings just because you have to do them. And especially now with the CMS standards, they tell you that you have to do them. Before, it used to be just Joint Commission accredited agencies or organizations that did it. Maybe organizations that wanted to go through EMAP accreditation process, they did it. But now you actually have to take and do it. So what I want you to do is get out of the mindset of this is something we have to do and something that you want to do. If you can't tell, I'm extremely passionate about emergency management. I love emergency management. I think it makes sense. I don't think that we get enough credit in this career field for what we do. And so it's very important for you guys to understand that an HVA is going to be the baseline of anything that you do. And what do we know about the base of any structure? It needs to be built solid, right? The foundation of any structure needs to be built very solid. That's where the HVA comes into play because that is the base of your entire emergency management program, or it should be your base. So what we're going to do is we're going to take and talk about the basics of an HVA in general. So what is an HVA? What does an HVA stand for? Hazard vulnerability analysis, hazard vulnerability assessment, kind of the same last word there means the same thing. Is it a risk assessment? It is, right? Why is it a risk assessment? Okay, so you're identifying what is actually possibly going to happen, how are you prepared for it, and then what does that actually give you for your risk. So there's obviously a cost-benefit analysis that's conducted. There's risk assessments that finance does. If you ask your finance people about a risk assessment on your organization, they'll probably tell you where they fit financially as a risk. What about THIRA? A threat and hazard identification risk assessment. Are they the same as an HVA? Are they the same as a risk assessment? Similar. How are they different? They are kind of the same, and that's why I put well kind of on the bottom. What about a hazard mitigation plan, county EM? They're kind of the same thing. So a risk assessment, an HVA, a THIRA, a hazard mitigation plan, or hazard mitigation assessment, they're all effectively the same thing, but they're all slightly different in the sense that a risk assessment really can be applied to anything. You do a risk assessment when you get up and decide if you're going to go to work, don't you? Every single day, you decide which route you're going to take. You decide, does the weather look okay? Am I going to take the risk of being cold if I don't wear a coat? You do risk assessments every single day. Now, you may not document them. Imagine if you had to document every single decision you made. But you do risk assessments every single day. So a hazard a hazard vulnerability analysis shouldn't be that foreign to you that this is something that's a really benign or a crazy thing that we are really scared of taking and doing. Don't let it be that. Let it be your base, your foundation of the rest of your emergency management program, and don't be scared of a hazard vulnerability analysis. So the basics of an HVA is we want to look at probability. We want to take and look at the impact that it has, and these are sometimes estimated impacts based upon your best knowledge. We want to take and determine your preparedness, and then ultimately that's going to take and give you what your relative risk is. And then you take and utilize those to take and figure out what type of plans you're going to develop, what type of training you're going to have, what type of exercises you're going to have, what type of mitigations does your organization want to try to accomplish, tapping into your local county emergency manager and maybe requesting hazard mitigation funds for them. So again, you're providing information to them, and maybe your hospital might be able to get some funding to fix some of the hazards or the impacts or lessen the impact of the hazards that affect you. So this is really in essence the formula. You take your probability plus your impacts, take away what you've done for preparedness, and that's going to give you ultimately what your risk is. That's the most simple formula that you can come up with. Probability plus the impacts, take away what you've done for preparedness, because again, we don't want to discredit anything that your organization has done, and then that's going to ultimately give you your risk. So probability, likelihood of a hazard incident that's going to occur. You have to look at why did you activate your emergency operations plan, or why did your hospital activate their disaster plan, their code white, code black, code red. What did you activate? Why did you activate it? What was the impact that you had on that? All of that information, which is why you document what you do, helps you when you go to look at either creating an HVA for the first time, or in all of your cases, revising your hazard vulnerability analysis. What other things have we been notified of that were really close to being bad things but never actually happened? Maybe we activated for a turned over semi on the highway, but we never received patients. Or maybe we were told that we were maybe going to get some water contamination, but we never end up receiving that contamination. Don't discredit that stuff either, because those simply are just near misses. That's really all that was. It was just simply a near miss. Your National Weather Service, which National Weather Service office do you guys utilize here in southwest Minnesota? Sioux Falls? So contact them, contact your emergency manager, contact the National Weather Service, and obviously tell your emergency manager that you're maybe going to have that conversation, because they might be able to connect the dots for you. And they're going to help provide you information, climatology information. They go back to a certain number of years, and they can give you some statistics on the number of tornadoes that have actually happened, the number of floods that have actually happened. That stuff is really relevant and really will help you out versus saying, oh yeah, back in 1986 we had the flood and the water was this tall. Well, that doesn't really do me any good when I'm looking at developing an HVA. Believe it or not, your local libraries will have a lot of good information about previous disasters that have happened in your community. They have old maps. They have old newspaper clippings and articles. The flood of 86, so I'm going to tell you my age here real quick. I was born in 1988. Anybody think how old I am? 30. I just turned 30. For me, that meant that anything prior to 1988, I had no clue about. Actually, I would say probably prior to 1995, I had no clue about. And so when I started at my agency, both at the county EM as well as at the hospital, I actually went to the library and said, hey, pull up all the news articles of natural disasters that happened in this community from 1975 or from 19 whatever it was we were looking at, all the way back to whatever. The librarian loved it. She actually got to do something. She was able to look up stuff for me, and I was able to read about the different disasters that happened. And one of the very first things was the flood of 1986. Did you guys have a flood in 86 over here? Michigan, it was terrible. It was a terrible, terrible flood. The Dairy Queen, or Dairy Dan, or whatever they called it, was actually floating down the road, and somebody took a picture of that entire ice cream thing floating down the road. That was a mile from the hospital. We didn't have flooding listed as a top hazard at all. And because we hadn't had flooding since then. And so that article helped me discover that there was a flooding risk that we had, and we had to address that in our HVA. Also, your community responders, clinical infrastructure, your staff members, and also the elders in your community. Talk to them, ask them. Ask your grandparents if they've lived in a community for an extended period of time. Ask them what disasters have happened. Ask friends, ask community members, ask responders. We all know there's that old fire chief around that's been doing it for 30-some plus years. Ask them things that they've gone on, and then back it up with evidence from the library, from the National Weather Service, from your local community. Those are all of the things or inputs that you have to help you assess your probability as it pertains to an HVA. Then from there, the Kaiser tool, which again we're going to take and talk about, talks about the impacts that would affect your organization. And we want to look at life safety, which obviously we know is the top priority when we look at ICS. Then we want to take and look at what type of impact does that have on our property. And where you start diving into some of the numbers to really give you a good HVA, consider your uninsured cost of damages. So you could have property damage all day long, and maybe you have $1 million rider, or maybe you have $1 million, and maybe the flood insurance that you have covers it. Maybe you don't have flood insurance, so maybe flooding would rank higher in regards to an impact versus a tornado because you have structural insurance, which is where you can take and bring your finance people in, your risk management people in, the people that are in charge of your organization's insurance policies, have them come in. And again, I'm challenging the way that you think about disasters and the way that you think about the impacts of those disasters. And then ultimately your business impacts would be your interruption of services, and also, again, do you have business interruption insurance? And what does it apply to? So all of those things help make up what your actual impacts are. And again, on the Kaiser tool, it assists you with addressing those. Then we're going to weigh those two things, probability plus preparedness, probability plus impacts against preparedness. Because again, we don't want to discount any of the good pre-planning that you've done. So this includes your emergency operations plan, your hazard annexes, your functional annexes. Who knows what the difference between a hazard and a functional annex is? What's an EOP first off? Let me back up there. Emergency operations plan. So it's how you get up and running, maybe your rules, your policies, procedures, the fact that you've adopted NIMS or the National Incident Management System, maybe you use HICS or ICS or Public Health ICS. It's basically the stuff that needs to be in a plan somewhere. CMS is going to want to look at it, but you don't necessarily want to take and have to pull it out and read it for the first time during an emergency. And really, you shouldn't actually read your basic plan during an emergency anyways. That's where your annexes come into play. Basically, those policies or those procedures that you've created, think of those now as hazard annexes. They're hazard-specific annexes because you've created them specifically for a fire. You've created them specifically for severe weather. You've created it specifically for a medical emergency. And a lot of people think that Code Blue doesn't really fit in, but it kind of does when you look at it holistically as it pertains to preparedness for your organization. How you activate your EOP is also in your basic plan or your base plan. And then your functional annexes are going to be things that you do as a function. So if you follow the hospital incident command system, you could potentially have a functional annex for each one of the positions within your hospital command center. So you could have a functional annex for incident commander, one for operations, one for medical care branch director, one for planning, one for situation unit. You're probably thinking, I only have 4 people that sit in my hospital command center, How can I fill all those positions? That's a whole different class that you guys have coming up in December, I think. But you can also expand functional annexes based upon evacuation. How do you actually evacuate your facility? What are your primary, secondary locations? And sheltering in place. So think of functional annexes of how you do what you do. That's what functional annexes are. Then from there, you want to take and look at your internal response. How quickly can we take and respond to something? How effective are we at responding to severe weather? How effective are we at responding to mass casualty incidences? What type of resources do we have? Have we exercised these things before? Have we been able to refine the time that we activate our command center in less than 5 minutes? Maybe we can activate the ability our surge team within 30 minutes. Maybe you're comfortable with those numbers. Do they meet best practices? Those are all of the things that you should think about when it comes to internal response. And then your external response is figuring out, okay, how can the community and also your outside responders take and assist you? And this is where your local city or county emergency manager can definitely come into play. There are a lot of organizations out there, and mine was one of them prior to me starting there, where they said, oh, the fire department will take and come in and do our decon. Where do you guys think the fire department's going to be at during a hazmat situation? They're not coming to your hospital. They don't, I mean, heck, we have like a 30% shortage in fire. Who's here fire service? Anybody? So we have what, 30% reduction in the number of people we're supposed to have in the fire service. And maybe it's even higher here. They're not going to your hospital. They're going to the disaster. They're going to the actual incident site to take care of that. So what I would say to you is that it's very important that you don't develop your HVA in a silo, that you work with your partners on helping. They will actually help you provide your probability. They will help you provide some of the preparedness stuff that they're able to provide to you. And again, that helps ultimately create your HVA. So really, in essence, by doing that, by involving your community partners, now you're accomplishing a bunch of CMS objectives when you look at developing your HVA. So then ultimately, what that's going to give you, probability plus the impact minus your preparedness, is going to give you your relative risk. And what you're going to want to do is develop 5 to 10 top hazards. And again, the Kaiser tool will actually automatically populate this for you. That is the 2008 or 2017 version of the Kaiser tool that I put together with some fake numbers. And so you can see that that's going to help develop your list of risks. What you do then with those is you focus on the foundation of your emergency management program, and you use that as the foundation of your preparedness cycle for your emergency management program, which a teaser is, we're going to talk specifically about that in Module 3. Conditions of participation, risk assessment, emergency planning include but not limited to all of those things. So again, if you use the Kaiser tool, which again I'll train you guys on, that helps address a majority of these things. So these are all the things that you have to think about when you look at developing that risk assessment or your hazard vulnerability analysis. So let me give you a little bit of history about how the emergency preparedness standards went live within CMS. So what is NFPA? National Fire Protection Association. Are they regulatory standards or consensus standards? Consensus, why? There's nothing that says in an NFPA standard that you must, you shall, you will. It's until a regulatory agency that has the authority to say that you're going to follow that policy or that set of standards, then it becomes regulation where you have to follow it. So NFPA in 2012, they created NFPA 99, and actually they had some versions even before that. But Joint Commission also created emergency management standards based upon some of the NFPA standards. Now keep in mind, NFPA is filled with individuals that make up sprinkler companies, fire alarm companies, other special interest groups, hospital organizations, local fire department, the UL, they're made up of people that have a vested interest in making sure that we have ultimately fire protection across the country. Now, it outweighs one another because you may have a fire protection company that's there that's saying, oh yeah, we want in the standards that you're going to put sprinklers throughout your entire house. Fire alarm company is going to say, oh yeah, we want you to have a fire alarm system throughout your house. But then you have other people that say, hey, maybe you don't have to have residential fire suppression system or a fire alarm system. So there's a balance that's played between the two of them. So up until those standards get approved or signed in by law by a regulatory agency, then you have to follow them. Now, you as an organization can choose to adopt NFPA standards because then that, in essence, kind of becomes regulatory for you. But Joint Commission took, and in 2009, they took out of the environment of care a lot of the emergency management type stuff, and they created their own chapter. So they have kind of been the leaders on emergency management in healthcare. And so the hospitals that were Joint Commission accredited or long-term care centers that were Joint Commission accredited, they've been seeing these things for years, and so they were prepared when CMS came live. Part of the authors for the CMS standards were also Joint Commission surveyors. They were the ones that helped author, along with NFPA 99, help author the CMS standards. Now, CMS chose not to take anything out of NFPA 99 like they did with the Life Safety Code, NFPA 101, where they adopted the entire thing and took stuff out. They decided to take and rewrite everything. So what I wanted to share with you is that Joint Commission's been doing this for a number of years, and so the CMS standards were not somebody just sitting behind a desk saying, oh, I want to pick on hospitals now and make you guys do this, because I know it may feel like that, but they have been written since like 2009. After Hurricane Katrina, they've really been focused on getting emergency preparedness in hospitals improved across the country. So what we're going to do now is we're going to take and talk about the tools used to take and develop an HVA. So this module, we're going to take and primarily talk about the Kaiser Permanente tool. Now, caveat, I'm not a member of Kaiser. I do not make money from Kaiser. What else do I have to say? I don't get kickbacks from this, but this is a tool that's really seen as a best practice. So for those of you that currently do not use Kaiser, you are more than welcome to start using this. I'm going to show you where this tool is. There's other HVAs that are out there, again, from ASHI that you can take and utilize. I'm sure you'd be willing to share those if you guys want to take and look at that. But the thing that is good with the Kaiser tool is that Joint Commission and CMS both have recognized it as a nationwide best practice. Now, with that being said, you will probably get some surveyors that are sticklers for one version of an HVA or a risk assessment over another. But a majority of them will probably be okay with the Kaiser tool. So if you use this tool and you use it properly and you have it actually as a base for your emergency preparedness program, you'll be fine. The other thing that's unique that I did for my master's program is I took a bunch of different templates, followed them all, and with the exception of maybe a couple that were like maybe number 2, number 3, or number 1, number 2, my hazards, my top 10 were all the same hazards. So it doesn't really matter the tool that you use, it's the process that you follow and the inputs that you put into the tool. So there are 2 templates that are out there live right now, and I've seen somebody with a computer up looking at the new template. There's a 2014 version, and then there is a 2017 version. So if you go to Google and you type in hospital HVA, the first link that will come up will be for the 2017 version. I think they call it updated HVA. And then if you go to the second link down, you can look at the 2014 version. And I'll talk about why I like both of them or why I don't like both of them. So 2014 template, who has this template that you use for your HVA? There's nothing wrong with it. However, there were a couple things that were missing from it. What was one of the biggest hazards that you guys found that may have been missing from using this 2014 template? It's in the news almost every single day in this country. I heard somebody say, active shooter. Active shooter is missing. So under the human hazards, so if you look here, you have these different tabs. So you have one for natural hazard, one for technological hazard, one for human cause, and one for hazmat. You have to do the HVA 4 different times, and ultimately you're going to take and get a summary of all of your relative risk. But when this was created, active shooters, even though they were big, it really wasn't a hazard that Kaiser thought of that would affect hospitals. They had hostages, because we've had hostage situations in hospitals for years. But they didn't really think about active shooter. So the new template, the 2017 version, they added active shooter in there. And I'll show you guys how you can unhide some cells or unhide some the bottom tabs on the new version, so you can actually manipulate your event or your hazard data over here to make it more specific for you. So again, 2014 template, you had multiple tabs on the bottom that were broken out into the different hazard types. You have your probability with a numerical value. You had your human impact, property impact, business impact. That's going to be your impact as a whole. Probability plus impact minus your preparedness, both your pre-planning, internal and external response. That's going to ultimately take and give you what your risk percentage is. Now, don't look at just the technological hazards or just the human caused hazards, because all of them tie in together to give you what your top hazards are when you get to the summary tab. The 2017 version, what's the biggest thing you guys have noticed now that's different, besides active shooters, the top one? Let me go back. So there's that one. What's different about this one? What's that? It's all on one sheet. So the tabs are no longer there on the bottom. So they've taken all of the potential hazards that could exist, put them all on one sheet. So Kaiser got feedback from a lot of organizations that said, hey, we did an HVA, and then CMS told us that we didn't actually do an HVA because we forgot about clicking on the other tabs on the bottom. We only did one or the other. They didn't do all of them. And so to combat against that, they created all of the hazards on one template now. What else is different? Again, I'll go back here. Okay, alerts and activations. We talked about those are inputs. You should think about the things that you are actually alerted about, and then what did you actually activate for? Now, what's really cool about this particular template, and the reason why I like it the best, is the fact that it allows you to track your incidences. Because we know we're going to develop AARs, but we don't actually have a one-page sheet that tells us all of the different things that we did throughout the year in regards to being alerted about things that could happen or the actual activations. So there is a separate tab in here that helps you provide your input of the activations and the alerts you've received. So you're able to put that information in there, and then it populates some graphs of saying, hey guys, in 2018, this was the HVA that you did. You tracked through all of 2018, all of your alerts and your activations, and these are the things you actually activated against. And you can compare, what did we say that we think was going to be a top hazard versus what was the actual top hazard that we activated for, and then that helps you develop your next year's HVA. So it's a continuous cycle. So that's why I like this tool, is that it will do that for you. Now, on that HVA template, if you go on the bottom, actually I'll do it right here. Let me show you guys. This is the secret squirrel stuff. Here we are. So the people on the phone probably aren't going to see this now, right? Okay, all right. So again, I just went to Google. Again, I don't get any kickback from Google. I'm not selling anything. I have to go to the caveat there. But basically, I typed in hospital HVA, and then you can see that there are two items that come up. You have the revised HVA tool, and then you have the hazard vulnerability analysis, which provides you a little bit more detail. So if you're looking at going in front of the C-suite and talking about what an HVA is, there's some language that will help you so you don't have to recreate it on the information. And you can see they have the revised tool at the top, and then they have the HVA template tool, which is the 2014 version down on the bottom. Again, if you click on the first link, just to show you, that I wasn't playing any tricks on you, you can click on this first one here, and it takes you straight to the 2017 version. There's an instruction sheet. Basically, is going to be everything I just shared with you about this tool, and then you can actually click on the tool itself. Now, I wanted to take and show you guys how you can customize some of this, because it's really embarrassing when you go in front of your C-suite, and who has the computer up right now that has the template on it? Scroll all the way to the bottom of your hazards and read what that hazard is. Zombies. Okay, so yes, that's a cool thing. You know, that's sexy, but it's not really professional. And so I wanted to show you guys how you could actually take and get rid of that that thing. Hey, look, there's a bunch open now. Imagine that. Oh wait, it's on my screen. There we go. I was wondering why it wasn't opening up. All right, so you have input. So you have the input. This is where you can, and I would take and erase Kaiser Permanente and put your organization's name up there. put your report year. And also, I noticed that a bunch of you said, we just did this in the spring, we just did this in October, we're going to do this in November. Who does theirs based upon your fiscal calendar within your organization? Anybody? Who does it based upon calendar year? Calendar year is really, really a good way of developing your HVA, because if you think about it, people tend to leave around Christmas time. It's usually a slower time. You're able to kind of recap your thoughts, think about the things you want to do, and you can develop priorities for the next year. So if you do your HVA in November, it gets reviewed and approved in December, then January 1, you can go live with your new priorities for that year using your HVA as a baseline. Some organizations that have like October through September as their fiscal year, they will choose to do the HVA based upon that because they want to take and harness budget funds to help mitigate the risks or prepare against the risks that you have. So again, you're able to take and tie this in to your budget process. You're able to tie that in maybe into your overarching emergency preparedness program. And if you arbitrarily just picked a date and it works for you, great. But I would suggest you looking at changing it based upon your fiscal year or change it based upon your calendar year, because it will help you develop your multi-year training and exercise plan. It will help you develop your priorities for year in and year out. All right, so HVA. So you have your input, which is basically your cover page. Then you come here. This is where you can put your data in. So you can put the alert category, what type of hazard was it, what was the alert type. This is where you can take and log that information I was sharing with you. And again, zombie shows back up. Oh, that darn zombies. We'll figure out how to get rid of that here in a minute. Was it internal, external? Who was the responder? What was the location? So there's a bunch of information that you can take and put in here. And the other thing that I like about it is I've actually added a column for my HVA when I worked at the hospital here, and I put AAR completed. And I put the date when it was completed, so that when I provided this cover sheet to Joint Commission, I could say, hey, here were all the activations that we had in this year, because we were surveyed every 3 years, so here's 3 years worth. And they would go along, they'd pick one and be like, hey, I want to see that. And I can say, okay, here's my AAR, here's the date for it, and I'd be able to pull up that after action report for them. And then they would always look at the improvement plan and say, okay, you said that George person is going to take and do this by this date, did that happen? And then we would find the evidence of standards compliance with them, show them. And so I use this tool more than just the HVA. I used it to help me track a lot of my emergency management required stuff that I have to do anyways. So then from there, this is where you can take and do all your ranking for your hazards. And again, if you change the input data, it will change name of hospital, I'll put that there, and then you have to change it up on the top of this template. And then ultimately when you're done, it's going to give you that risk, or the summary. It's going to give you a nice, beautiful little graph that you don't have to create yourself. You just snip it from there, and you can throw it in your PowerPoint presentation, but it shows you what you said were going to be your top 10 hazards, and what were your actual alerts or events or incidences that you had in your jurisdiction. Now, if you notice, there's something missing. Well, actually, you won't notice because I didn't unhide it yet. Oh, come on. Oh, no. All right, well, I'll just open the other one up. So you can go down there on that tab. Oh, I know why. Hang on. I fibbed. All right, you can come down here, and you can unhide a tab. And I want to unhide my reference tab. Now I can come in here, and I can manipulate those event names, and I can get rid of zombie. I can get rid of other. I can get rid of a lot of the things that I know for a fact have zero impact against my organization, like a volcano. Yes, it is possible that a volcano could happen, but if a volcano hit my hospital in Michigan, my HVA is going out the window anyways, because we're not prepared for that at all. That's one of those high-risk, low-frequency things that's almost a no-frequency incident that really doesn't matter. But you can manipulate these names. You can make them fit your organization better. Now, I caution you on doing too much customization, because then you're not able to meet what you have in your locale or your emergency manager. Maybe you, instead of civil unrest, you have civil protesters. They kind of mean the same thing, but if the county has in their hazard mitigation plan civil unrest, you probably should follow some of that same naming nomenclature, some of that naming convention. So again, you can go through here, and once you delete some of those, so like we're going to get rid of zombie here. Now you'll notice on my data set, my alert type, zombies is gone, right? Magic. But on my hazards tab, it's probably going to give me like a exclamation point. Oh, it did work. Sometimes it will give you like a hashtag with the word def on there. What that means is that particular formula has been broken, and all you simply have to do is just delete that particular line or that particular row, and then that data goes away. It doesn't affect the data pertaining to the relative risk as a whole. But again, I wanted to take and show you guys, you would come down here, unhide the reference tab. Don't unhide any other tabs because that's the formula that's used to give you what your risk is, and they're very weighted, specific formulas that are best practices. But again, you can customize this data to fit your needs. As long as you got values at the end, you didn't screw up everything. If you didn't get values at the end, or all of a sudden like it's a 59% as one and the other one's like 5,000%, you obviously screwed something up. Or it's a really, really high hazard. But most likely the formula was screwed up, which is why I didn't want to show you guys how to untab or unhide those. Also, I don't want you to manipulate the data to get what you want. I know there's a lot of places that will say, you know, I really want this cool gadget and I know I have to use my HVA, so we're going to rank it really, really high so we can get this new gadget. Don't do that. It doesn't do you any good other than maybe getting you that new gadget. But yes, you can go through here and you can manipulate this reference material, and then that will ultimately portray into your alert types and also the hazards or the event types for the HVA. All right, so you got a couple minutes to think. Maybe not. Maybe I didn't give you much time to think, but what do you guys think so far? Am I posing more questions than answers for you? Absolutely. Who does their HVA by themselves? You sit at your desk and you just do it because you have to. And again, don't be ashamed. It's okay. Do you do it amongst a committee within your organization?
A small one.
A small one, and that's okay. But maybe now you can think about other people even in your organization, not alone just outside of your organization, that you could maybe include, like your finance people, your insurance people, your risk management people. Those are people that have traditionally not been involved in the development of an HVA, but they provide you some inputs, because that's going to change your preparedness levels a lot, whether you're uninsured or you are fully insured on something. All right, so what we're going to do in this module is we're going to briefly just take and spend some time talking about the applications of the HVA. So we taught you probability plus impacts minus preparedness equals your risk. We talked about the different data sets. We talked about the different tools that exist out there. We have an example of what the Sanford system uses. We have the Kaiser tool, the ASHI tool. There's other tools out there that help you develop your HVA. And now we're going to take and talk about really basic emergency management practices, and again about how the foundation of the HVA helps for the rest of your emergency management, emergency preparedness program. So again, the HVA should be the starting point of anything that you do for your emergency management program. So you figure out who you're going to have, and then you develop that HVA. And what I mean by who you're going to have as your core emergency preparedness team. Who are you going to have help provide that input into your HVA? Who are the people that need to come every month, every quarter, every other month to talk about emergency management? Who is going to take and talk to the local police department or the fire agency? That's where the HVA comes into play, is helping you figure out who your planning preparedness team is going to be. So who's seen this before, the preparedness cycle? We know it's an ever-evolving cycle. It's always moving. It's basically multiple wheels spinning at the same time, because we all know that we don't prepare just for one hazard. We prepare for a lot of different hazards, and we're in different stages of each one of those hazards. But generally speaking, the preparedness cycle is a continuous cycle that starts with planning. And the very first thing you do in planning is you develop an HVA. Then you work on organizing and equipping, getting your team around, buying equipment. Then you have to train on your policies, your procedures, your equipment. You have to train the people that you have designated to be part of your emergency management team, whether that's a hospital decon team, whether that is your response team, your incident management team, your long-term care center incident management team, whoever it is. And then you have to exercise. And again, we'll go into detail here on exercising just a little bit. And then ultimately you want to take and evaluate what went well, what didn't go so well, and improve on those. So first thing you do, develop a preparedness planning team. This includes agency organization representatives, community responders, other healthcare organizations. If you have large private sector partners in your community, they will typically have an emergency manager. They may call it a business continuity specialist. They may call it a risk manager, but generally speaking, they're all doing the same stuff as you guys are, emergency management. Then you have to figure out, okay, what are the hazards that could affect us? Now, the Kaiser tool already gives you a lot of the different hazards that could affect you, and that's where you can take and customize it to fit your organization. Again, get rid of zombies. It's never more embarrassing than taking a CEO, a HVA, and there's zombies on there, and you ranked zombies as your highest hazard. It's embarrassing. But if your CEO was like mine, he actually would have thought it was funny and probably would have went with it, but for some, they may not find that all that funny. Then you want to take and develop your HVA. Your HVA should be your basis for your emergency operations plan. We know your emergency operations plan is going to be all hazards because that's going to have the general rules, regulations, the stuff you have to follow in an emergency management program. And a lot of the stuff that has to go in a basic plan is available actually in the CMS standards. There's another standard out there that can help you. It's called CPG 101, Comprehensive Preparedness Guide 101. So CPG 101 is the base planning document that FEMA has created that jurisdictions, hospitals can take and use. It does have a jurisdictional emergency management focus, but you can adapt it to your hospital. Or you can find a company and buy a template from them. You can get a template from people in here, or you can utilize what you already have. Again, your EOP overarching document, that's what we call it, should contain your basic plan, rules, regulations, hazard annexes, and functional annexes. So we're going to take and talk about flooding as being a hazard. So, for instance, flooding is determined to be a high-risk activity for you. You probably should take, now that you have went through the HVA process and you know that flooding is a top hazard, you should figure out, okay, who do we need to get involved to learn more about flooding? So that's part of the organizing. Do we have to buy sandbags? Do we have to buy a sandbag machine? Maybe what we do is we develop a plan that when we know we're going to get high amounts of rain, that we send somebody from maintenance out to go clear all the drains from all the leaves. Maybe we decide that we're going to take and buy rock instead of mulch on our property because we know that mulch will get picked up and that blocks the storm drains, which then ultimately takes and causes flooding, versus if we bought rock, rock isn't as easily picked up by floodwaters, won't block our drains, then it won't take and flood our organization. So those are all preparedness activities. Again, weird things that you wouldn't normally think about that you now can take and think about because you developed a really good HVA, thinking about all the things that pertain to that particular hazard. Because again, we talked about all of the different inputs for the probability. So then from there, now you're figuring out, okay, what are other things that we can take and do? Do we have to have a response plan so that when we have flooding in our organization, maybe we look at the different types of water. Is it from a pipe break? Is it from external sources? If it's external sources, are we considering it to be contaminated water? Are we making an assumption that it's clean water? How do we take and do the cutouts of the drywall? How quickly do we have to take and put drying on there? What policies or mutual aid agreements do we have with different cleanup companies like Belfor, ServPro? What other companies do you guys have around here that do, what's that? Okay, ServiceMaster. Do we have to have contracts with them? Again, if flooding is not a hazard for you, maybe you don't have to have that. Don't spend a lot of time or effort on it. But if flooding is your top hazard, you should be thinking about things to take and prepare for flooding. Because you will inevitably, because your HVA told you so, that it's probably going to happen. And there's a high impact on our business. There's a high impact on life safety. We don't have flood insurance because maybe flood insurance was too expensive, or maybe we're self-insured and we're going to take and just take care of it ourselves. So then from there, you start thinking about, okay, now we're looking at capital budget projects. We know that our generators are in the basement, and we know that 10 years ago the basement flooded before we had those generators in there, and we really didn't take care of the cause of the flooding because we can't. So maybe we need to bring our generators up, or maybe we have to take and put some flood diversion or water diversion stuff around that room where the generators go into so they won't be flooded. So now you're starting to think about mitigation strategies, and again, if it's an opportunity arises, tap into some of the funding in your county with your city or county emergency manager, especially when they look at hazard mitigation funds. There could be a potential for you to receive some federal money to help you fix your problems in your organization when it comes to mitigation strategies. Now, where it comes tricky is when you have multiple facilities. So you have the option, CMS allows for you to choose, do you want to do one HVA that encompasses your entire organization, or do you want to do an HVA for each one of your sites? Now again, surveyor bias. If you choose to do one, and I'm not a surveyor, but surveyors, I've heard this from them before. If you choose to do one for your entire facility, and in one facility you are 2 counties away and there's a railroad track that runs right next door to them, and your hospital doesn't have a railroad at all, and you ranked railroad almost nothing, there's going to be a problem there because you're not actually addressing the hazard for your particular building. So I'm not going to say one way or the other where you need to have one for every single facility or you need to have one for your organization, but think about the impacts of you choosing one way or the other. The more you do, the more likely you're probably going to get caught with not having something done right. But in the same sense, if you don't do it for all of the other organizations, really, does that actually do you or your staff or your patients any good? Because maybe you're not addressing the right hazards. All right, so once plan and mitigation strategy has been developed based upon the HVA, then you need to start thinking about what are you going to do to purchase to fix things. So maybe you're adding additional drains, maybe you're elevating utilities, relocating department services, you're doing some of those mitigation strategies. By definition, if you look at the FEMA definitions, mitigation is going to be permanent things that you do. So preparedness, actually sandbags are considered to be a preparedness activity because it's not something permanent that's going to be in place. If you physically moved a drain from here to here, that is a mitigation strategy because you're trying to lessen the risk to what she had stated. You're lessening the risk. So keep in mind, mitigation are going to be permanent things that you do. Preparedness activities are temporary things that kind of go into place to help you lessen the impact, whereas mitigation is you're trying to lessen the impact permanently or over a longer period of time. So again, none of your answers were wrong. Just by definition of what FEMA defines those as, mitigation is permanent, preparedness is temporary. Now, the reason why that's important is that it kind of ties into your ideas of capital budget. Mitigation should be the things that you want to do long term. So when you make a decision to do something, make sure it's a really, really darn good decision so that you don't have to go back and move it 10 years later or 5 years later or 2 years later or 2 months later next time the rain happens because you figured out you put the drain in the wrong spot or maybe you didn't elevate the utilities high enough. Do you guys know why you have to have your plugs 18 inches off the ground in houses? To lessen your shock risk in case your house floods. That's why the National Electrical Code, which is part of NFPA, tells you that plugs have to be up, the bottom of the box or part of the box has to be up at least 18 inches, is to prevent any flooding. Construction guys, you guys are maintenance guys, right? Do you put your drywall all the way against the floor when you do new construction below your baseboard? You raise it up a little bit so that if water happens to get on the floor or even just spilled, it doesn't actually wick up into the drywall. So again, those are things you guys already do. They're mitigation things that you already do. You just don't know that you're actually doing them. So again, flooding is something that's near and dear to my heart. We had 7.5 inches of rain that fell in 45 minutes in a hospital that has never been in a flood map ever. And we had 36 inches of water. Again, 7 inches of rain doesn't really make sense of how it's 36 inches of water, but you have 36 inches of water that flooded the entire first floor of the hospital. 1.2 million square feet of drywall had to be taken and cut out of the first floor of the hospital. It affected the 72-bed ER. It affected radiology, nuke med, where we had our radioactive isotopes. It affected that. It affected pharmacy. It affected central sterile. And our cafeteria was all impacted by the flooding. So flooding is near and dear to my heart, and it happens. Flooding, ironically, was number 3 on our hazard list. But it wasn't for external flooding because, again, we said that it wasn't due, or we're not on any flood maps. We did it because we had failing infrastructure. The hospital building had been built in the 1980s, designed in the 1970s. We had failing infrastructure. And so we were actually afraid it was going to be a pipe break. But the great thing that we did for our preparedness plans is that we developed plans based upon all hazards of flooding. So it didn't matter if it came from a pipe break or if it came from the ground or if it came in from outside. Our response was going to be the same no matter what. And we actually opened up half of our ER, so we got 35 beds back within 4 days. And then we opened up the other half of the ER a week later. We had a music festival called Faster Horses that was coming in, so 65,000 people were coming into town that Friday, and we were able to get our ER open in time for the music festival as well as the balloon festival. But if it wouldn't have been for an HVA, for us to say that flooding was a hazard of ours and it was a top 3 hazard, and we actually, if we wouldn't have developed plans, our response would not have been as good as it was. And they're still doing some recovery from it. There's a bunch of legal stuff that's going on between the different insurance companies and blah, 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 stuff that I don't really care about, but you should have to care about because it does impact you. $6 million so far is the loss that we had from that flooding. So next, your HVA should help you figure out what type of training you're going to take and develop. So you figure out, okay, hey, fire's really high on our list. We're really not prepared all that well. We take and develop a plan. Now we need to actually take and train on that plan. So it's educating staff on a new piece of equipment, new policy, new procedure, new anything that's new, you conduct training on. Now, there's training that you can do that applies to all hazards. You could go to the CDP, you could take ICS training online, you can come to the training here, you can come to the coalition. All of those things count for training because you're going to respond, or you're going to utilize that training to respond to various different levels of hazards. So don't be so narrow focused in your training on only particularly focus on one hazard. Know that you can do a lot of training that focuses on other hazards. And then of course you need to take and follow a building block approach to your exercise program. And this is where my public comment for the CMS standards came into play. It's saying, guys, this is what every hospital, every public health, every long-term care entity should be focusing on. We shouldn't be jumping into every single year doing a full-scale exercise and simply just following the process to take and do one when we're actually not learning anything. We should take and spend some time on discussion-based exercises, tabletops, actually having strategy sessions on understanding our policies, understanding our procedures. And then from there, you take and you conduct a drill where you're focusing on one particular component. Maybe it's activation of your hospital command center. Maybe it's activation of your long-term care incident management team. Maybe it's getting your pod set up and you're going to do it in 30 minutes, or maybe you're going to do it in a day. Maybe you're going to filter a certain number of people through. That is a drill. Functional is where you bring a group of people like this into a room, you have a sim cell or simulation cell, and you're feeding real-time live injects into them. They think the world is falling down around them, but yet it's beautiful, bright, sunny day outside, and they're just dealing with the emergency disaster. And then your full scale is where you bring in multiple different entities together to take and conduct the exercise. So keep in mind, the more complex the exercise is, the longer it should take you to take and actually develop that exercise. A tabletop exercise, a good exercise designer could probably take, if they dedicated time, could probably take and develop a good tabletop exercise, maybe a seminar, workshop, something like that, within a month or two. If you have to space out your meetings, because there's an HC process to develop your exercise, if you have to space out your meetings, maybe it'll take a little bit longer. A full-scale exercise to be done correctly, because again, you're thinking about developing the plan, conducting training, buying equipment, conducting training on that, getting your people around, conducting training on that, working on developing a tabletop exercise to make sure everyone's aware of the plan, conducting training on the after-action report. Then you take and do a drill. Then you conduct training on the after-action report. Maybe you revise your plan. By the time you get to a full-scale exercise, from the time you think about it to the time you actually conduct it, should be about 12 to 18 months, because you're doing other stuff along with it. Now, I see you're smiling because you've probably had your CEO come up to you and be like, hey, by the way, I want you to take and do a hazmat exercise, and you're going to do it next week. Who's ever had that before? I see some people laughing. I've had that before. My boss at an undisclosed agency came up to me and said, hey, by the way, I want you to take and do this type of exercise, and we're going to involve these agencies, these organizations. Oh, and I already have it scheduled for next week, Tuesday. The CEO is coming out. This is Friday. I don't have much time to do that. We did it. Didn't go so well. We learned a lot, but just know there's lots of different types of exercises. You should follow a building block approach. You use your HVA to take and develop your scenario. That's the particular hazard that you have that you use in the exercise. There's not going to be a single surveyor that is going to knock you because you developed a plan and a policy and a procedure, and you conducted training and you conducted exercise and you figured out how you can take and improve because you did something based upon one of your top hazards. You're not going to find a single one. And if you do, have them come and talk to me, because I'll talk them out of whatever citation they're going to give you. Because it just doesn't make sense. It doesn't make common sense. Common sense should tell you that you should take and prepare for the highest hazard that could take and impact you. Now, keep in mind, the highest risk, not highest probability. And we were talking about this during lunch. Snowstorms, blizzards. You guys deal with them every single day, but yet it's your top hazard. Should it be your top hazard? Should it be? Again, I'm not convincing you one way or the other, but I have this question a lot with my own hospital. We had infant abduction as one of the very top hazards. Why? Because it hits a reputational impact, and unfortunately our committee was filled with a bunch of people that were thinking a reputational, not actually looking at emergency management holistically. So that particular year we ranked infant abduction the highest. But it was cool because it allowed us to take and actually install an infant abduction prevention system, HUGS or something like that. And so we were able to get some funding with that because our HVA helped us with that, which now I know why those people were attending that meeting, because that's the system that they wanted to get. They pulled one over on me. But keep in mind, everything you do in your HVA should play into the rest of your preparedness cycle. So today, we're not going to get through all of these hazards, but I'm going to set you up so that our goal is going to be to get through these. But again, you're probably not going to get through them all, or you're going to think about things differently. But ultimately, we want this HVA to help you as a coalition figure out what you guys want to do this next year. Obviously, we have grant requirements, so there's certain things we have to do, and hopefully those grant requirements match or meet up with what the current trends are for hazards, but there may be some things that surprise you guys. So your probability, previous emergency operations plan activations, previous notifications, alerts of incidences, National Weather Service, local libraries, community responders, critical infrastructure sites, staff members, elders, etc. Again, known risk, historical data, manufacturer, vendor statistics. So active shooter, likelihood that an active shooter will occur within your region. Low, medium, or low, moderate, or high. So it comes down to what you have in your jurisdiction. So it's both. It's known risks of things that could happen and the things that have happened. So have you had any active shooters within your region? No. In your region, as a coalition, have you had any active shooters that have impacted any one of your organizations in the past, let's go since July? How about before that? Okay? So even though it's a hot button topic, I'm probably not going to rank it low just because there hasn't been anything, because there has been things that have occurred, and the likelihood that something could happen is probably there. It's probably more than low, but I wouldn't think it's high because you haven't had anything. So again, that's where you weigh out what could be versus what actually has happened. And again, you have to make a decision on that. So where you could document your decision on this particular active shooter component was that even though nothing has occurred within our region within the last 12 months, there have been an increased number of active shooter responses across the country. Look at the FBI data. There's an actual FBI agent that specializes in getting the data related to active shooters. You can go to their website and you can get data from that and reference that data. Again, if you start showing federal references to a CMS surveyor, they're going to love you because you're showing that you actually did some evidence or you did some research on figuring out how you're going to rank something. So for me, I would probably rank it moderate because the society today, pun intended, is more trigger happy than it used to be. So for me, in my organization, I'd probably rank it, actually my organization, we ranked it high because we had an active shooter in our hospital. We had an individual that came in with a gun, barricaded himself in one of our family waiting rooms, and then he was a psych patient because we had a psych facility in our hospital, and he called 911 saying that people were surrounding him with guns. We thought we had multiple active shooters in the hospital. Well, it was him seeing law enforcement surrounding him. Ultimately, he never ended up shooting anybody. We were able to rescue him, intervene with him, and get him the proper care that he needed because he was going through a mental health crisis. But we ranked ours high because we actually had that in our community. We also have 3 to 4 shootings a week that occur in our community, and we actually had to have law enforcement bring down an individual by gunpoint who was the victim of the shooting the day before, who ended up being the shooter that day of during our flooding in July. It's absolutely crazy how to fathom it, so we ranked ours high. But for you guys, I would probably say somewhere between low to moderate. So as a consensus, what would you guys like to rank it as? Moderate, okay? All right, now we haven't had any hazards, we haven't had any activations, so those are 0, and again, that would come from the data that you inputted over here. And again, it will update as you go through. But all right, so let's talk about an active shooter, human impact, possibility of death or injury. Okay? So potential for staff death, potential for patient death or injury. So I would say it's definitely high. Okay? Property impact, physical losses and damages, cost to repair, cost to set up temporary replacement, cost to replace. So you could think about equipment, but also what about the psychological impact that goes into an active shooter? Yep. So we're going to talk about that in business impact, absolutely. But property impact, Sandy Hook, even though that they had that school on slate to be demolished and to be replaced with a brand new building, there was no way that students could go back into that building seeing what they seen. The teachers couldn't go back into that building. So there is, with active shooters, again, if you think this way, there is a high property impact potentially because there's a psychological impact. And again, one person being shot versus 50 people being shot, it could weigh it one way or the other. That's, again, why I say it depends. But again, you document in your HVA why you chose what you chose. Business interruption, employees unable to work, customers unable to reach your facility, company in violation of contractual agreements, fines or penalties or legal costs, interruption to critical supplies, or interruption to product distribution. Now, the other thing to do when you're doing this back at your site is capture some of those conversations, because people will come up with really, really good ideas, and don't forget about it or don't discredit it just because you're doing it during an HVA, because maybe you don't have time on the agenda to talk about it today or at your meeting. But somebody could come up and say, hey, you know, I heard about this really cool training that we could do. Maybe we can increase our preparedness. Document that, and then go back to it again when you're developing your multi-year training and exercise plan. All right, internal response. So response as a agency. Let's go with that. Let's go with that philosophy. Do you think it's less likely that you will have a bomb threat versus an active shooter? So that's the other thing that I do too, is I always pose that question back with my group. When they make a decision, I say to them, do you think it's less likely that you'll have this over that? Do you think you're more prepared for this particular hazard versus that hazard? So I like to go back and revisit some of those things. All right? So we know that we've had one activation or one alert, but again, we'll figure out how to put that in here in a little bit. All right, so possibility of death or injury for a bomb threat. Now, we didn't say explosion, we said bomb threat. There's a difference. You could have an explosion come from a bomb, but we're specifically talking about a bomb threat. What type of life safety impact does that have when you have a bomb threat? Okay, it could be NA, it could be low. Who has that you evacuate? Let's say, for instance, and again, we're talking about the coalition, but I want to help you think about things for your organization. What happens if the bomb threat's in your critical care unit and you have to move those patients? Then your life safety could potentially be higher, right? So again, you have to think about how you want to document your assumptions. Now, I'm not saying to think about that way, but I wanted to give you something else to think about. I would honestly say, again, my opinion, my professional opinion, a bomb threat does affect your business more than it affects your property, and probably more than it would impact your life safety, because that's really what the problem is. You're impacting your business. That's the whole purpose of a bomb threat sometimes. Think about, why do kids call in bomb threats in schools? Because they don't want to go to school. They want to interrupt the business of the school. This is tough stuff, isn't it? It's really tough, because you guys are all running through your minds all of the bad things that could happen. And you're sitting here thinking, gosh, that dang guy from Michigan is telling me I'm going to rank it this way versus the other way. I just want to pose the questions, because these are the questions you're going to get. We're over on time, but another tip that I can provide to you guys is, if you have a good, strong emergency management program, you feel like you have a good, strong working relationship with those people that fit on your organization. Again, you're not starting this from scratch. You have something that you're able to work from previous years. What I did as an emergency manager is I would come to my committee with an HVA already filled out, and the rationale and the reasons why I did what I did on my HVA, the assumptions we made, and it was actually my department. And we were more conservative on how we rank things, because again, we think like disaster mode all the time. That was the way our department worked. And we pitched these ideas to our committee and said, do you confer with this or not? And we had a lot of discussion where we went back and forth, but it helped speed up the process where we presented with a completed HVA already. Now, John did provide me with your 2017 HVA, and I chose not to use that. And I think, John, probably the best step for you would probably be to bring that to them and say, what do you guys want to rank now, putting it on this template if you would like. And then you have those discussions on it. But I wanted to start from scratch, because I want to go with the lowest common denominator, that there may be organizations that are going to this template, or maybe you don't have a good HVA. Maybe somebody else did it for you. You don't know the rationale behind it. That's why I did it this way. But I wanted to at least show you guys, these are some of the discussions you'll have to have when you're looking at developing your HVA. Yeah, so keep in mind, this template was created for an individual facility, an individual entity. This was not created for a healthcare coalition. So you have to figure out how to adapt it to a coalition. So in that particular sense, I would think about, what's the largest probability across my entire coalition? What's the probability that an earthquake will occur? Yeah, it's probably going to be very, very high for facility A, because they're on the fault line, versus facility B, C, D, E, F, G, H, I, J, K, L, M, N, P. But where does it rank as a region or as a coalition? So think about it holistically as, how many counties do you have? 16 counties, 40 hospitals, however many long-term care facilities. Think of it that way. The last thing I'll leave you with is the fact that, so my hospital, when I first started in healthcare, I went from the county sheriff's office to my hospital. They had dam failure as one of their top hazards. It made sense. There was a dam that was in our jurisdiction. But sunny day failure versus rainy day failure, they never knew to actually ask the infrastructure company that had that dam what the differences meant. Rainy day failure is going to affect one house. Sunny day failure is going to affect 6 houses. The difference between the two, rainy day failure means something's already flooding those houses and probably already evacuated. Sunny day failure, nobody's evacuated. It's basically a bomb is blowing up the dam. They ranked that so high. It was 26 miles away from the hospital. Dam failure really didn't affect us at all. Well, it affected mass casualty surge, but it didn't affect us from a dam failure. So go back. I challenge you to go back and look at why you decided what you did based upon your HVA and see if you need to rethink about it and think about it differently and redo it. So when you're getting ready, a lot of you guys have coming up next month to redo this, think about why you did what you did and see if you guys need to rethink. Thank you all very much for your time. Hopefully this was worth your while. Hopefully you got something out of it. And I appreciate you guys inviting me over here. Thank you.